Members, good morning. It's the appointed time. We have a quorum. I call the meeting to order. This is the panel on health services. Item 1. Information papers issued since the last meeting. The Secretariat has sent 5 information papers to members. I ask members to take note of them. Item 2, items for discussion at the next meeting. On the 12th of June, Friday, we will have the next regular meeting. The government proposes 3 items: strengthening professional regulation of healthcare services, healthcare manpower projection 2026, and action plan on weight management. Any views? Ms. Chan? Ms. Rebecca Chan? On the last occasion, we have expressed views about some items that are of concern of members. I think that it would be better to have 2 items in each meeting, because more than that, there won't be enough time for members to have a detailed discussion. This will be a disservice to ourselves and to the public. Perhaps we can keep the items for discussions at 2 in future meetings. We will talk to the government about the number of items. I do think that it's a bit rushed because there are a number of items. Perhaps we can extend the length of the meeting. Would you agree with that? In the last meeting, there are 3 items. Perhaps we can put forward the start time of the meeting. Mr. Ben Chan, Dr. Ben Chan. Yes, I'll leave it to you to make arrangements. But it is our standard practice to have sufficient time for discussions. If we have 3 items, all of them are of concern to members, it will be very difficult to cater for each and every one of them. I ask you to talk to the administration. If necessary, we can reduce the number of items. By extending the length of meeting, there is always a limit. So I ask you to maybe reduce the number of items to 2. Perhaps we can have more frequent meetings instead. We will talk to the administration about the arrangements of 3 items for discussion. If possible, we will make adjustments. Otherwise, we will extend the meeting. Item 3, implementation status effectiveness of public healthcare fees and charges reform, including drug subsidiary arrangement. We have invited other non-panel members to join this meeting. Let's invite the administration to come in to join us. We have received 3 submissions. They have been sent to members before the meeting for their reference. I understand that a lot of members would like to express their views. Time is tight, so please be succinct. If someone has already spoken on an issue, please don't repeat it. Members, if you'd like to speak, please press the request to speak button. The administration has given us a supplementary information paper. It's been tabled for your reference. Let's welcome from the administration, Professor Lo Chong Mao, Dr. Libby Lee, Mr. Raymond Wu, and Dr. Wong Yu Chong. We'll first hear from the Secretary. Thank you. The public healthcare system is the cornerstone of our healthcare system. It's a safety net for all. We have to ensure its sustainability. With an aging population and increasing demand, as well as advancement in medical technology, we are working to deepen the reform of healthcare, one of which is fees and charges reform, which is indispensable. The reform was introduced on the 1st of January this year. In general, it's been quite smooth. We want to enhance protection for poor, acute, serious, critical patients and make better use of public resources. We have seen results. With the implementation of the reform, we maintain 95% of subsidy, which is on a high level. Co-payment stayed at 5%, which is very low. In terms of helping the poor, we have expanded the waiver mechanism. Eligible applicants has increased from about 900,000 to about 2 million people, which is significant. There will be the additional 1 million low-income earners. They will benefit. That means more than 1 out of 4 citizens will benefit from the waiver. In the first 3 months, the HA has approved over 220,000 applications. 96% of them receive a full waiver. In the past, it was about 14,000 recipients of full waiver. Is an increase by 16 times. We have also streamlined application procedures. A lot of patients have indeed benefited from the reform. Excluding those who received the waiver before and after the reform, in the first quarter of this year, over 391,000 attendances have received a waiver, among which over 90% of them received the waiver for the first time. That means before the reform, these patients had to pay, but now they don't. The number of people benefiting from GOPC as well as FOC, and it registered an increase of 30 times, as well as a significant increase. In relation to supporting A&E acute cases, in the A&E in the first quarter of this year, there has been a reduction of attendances by about 10%, mainly for CAT 5, non-urgent, and CAT 4, that is a semi-urgent. In relation to CAT 5, there is a marked reduction of about 22%. By contrast, for CAT 1 critical and CAT 2 emergency, after the reform, attendances receive full waiver. The number of attendances has increased slightly by about 3.9%. For CAT 1 critical, 0 waiting time, and CAT 2 emergency treatment within 15 minutes, we have met the pledge. For CAT 3 urgent, the waiting time has reduced from 24 minutes to 20 minutes. So those who have received treatment by within 30 minutes, the number has increased from 82.2% to 88.4%. It shows that we have significantly enhanced protection. This also enhanced the ability for the A&E to divert resources to treat critical and emergency cases. There are also resources to promote chest pain centers and stroke channels. We have a cross-disciplinary collaboration through Green Channel. The treatment time has reduced from 90 to 80%. We have also increased the survival rate. In terms of protecting serious patients, we have offered an annual cap of $10,000 on fees and charges without means tests. It greatly helps those who are suffering from serious and chronic illnesses to not suffer as a result of not being able to pay. We reckon that the number of patients will increase. We have so far approved 3,000 such cases. Once the cap has reached, patients don't have to pay any further. We have set out the details in the annex. In terms of helping critical cases, drugs and medical devices is an important part of our system. We have, as a result, provided more incentive to use better drugs and devices. After the reform, DHA has introduced more drugs and devices to the safety net as well as the drug formulary. 11 drugs and devices have been included in the formulary, 8 of them subsidized by the government. Additional expenditure is about $130 million. In relation to clinical application indications, we have introduced new items in the Samaritan Fund. In the first 3 months, we have approved about 17 items with an expenditure about $40 million. We plan to introduce more. Thirdly, we want to enlist more more drugs into the safety net. Take dasatinib, leukemia drug, as an example. It was reclassified as a self-finance item under the special drugs category. The cost has dropped from $20,000 to $40,000 to just $20 per week. Over 400 patients benefited. We also aim to enable more households, including middle classes, to benefit. In the first quarter, the number of subsidy has increased by about 20 and 40%. For non-CSSA recipients, the number of applications approved has increased by 15% as well. A lot of the cases belong to the category of people who were otherwise unable to be eligible. The copayment rate has also dropped. These measures have shown that we have aligned with the spirit of increase and reduction appropriately. In addition to reducing the number of attendances at A&E, we have also reduced medication wastages. When it comes to as-needed medications, the overall demand has dropped. In the first quarter, there is a reduction by about 7%. For some drugs, say for example those that treat constipation, there has been a 43% drop. It's a bumpy road. However, we have taken the first important step. We have enhanced protection for poor, acute, serious, critical patients. We have reduced wastage. This will enhance the sustainability of our system. We'll closely monitor the implementation of the reform. We will be orderly and gradual. We will, according to the established mechanism, conduct a review once every 2 years. We want to ensure that the 5-year reform will stay on course. We want to expand and strengthen, widen our safety net. The suggestions given by members will be seriously considered by the government and the hospital authority, HA. Thank you. Let me read out the names who have pressed the button. First, Ms. Elaine Chick, Mr. Perry Chen, Mr. Adrian Ho, Mr. Chong Ho-fung, Ms. Christine Fong, Mr. Chan Hok-fung, Professor Chen Wing-kwong, Dr. Ben Cheng, Ms. Rebecca Chen, Reverend Peter Kuhn, Mr. Kingsley Wong, and Mr. Peter Shiu. Each member will have 4 minutes, questions and answers included. Please be succinct because we have quite a number of members. Ms. Chick, thank you for giving me the chance to answer, even though I'm not a member. I want to ask about the annual cap of $10,000. Currently, patients will have to check the balance available. When it reaches $10,000, they will have to make the application at HA Go. As far as I understand that there is no retrospective effect. It seems that the government doesn't have the initiative to save for patients. Patients will have to fight for it, and they will have to monitor the level of spending. Are there a lot of people who have reached the $10,000 cap without making an application? What is the percentage? Since you have the annual cap of $10,000, can you introduce an automatic waiver without patients having to make an application? If not, would there be a prompt in HA Go for patients telling them that the accumulated spending has reached $10,000? If need be, they may make an application. Will you consider introducing this function? Otherwise, patients will have to constantly monitor the level of spending. This will reduce their sense of happiness, and they will have to worry about having to check all the time. Secretary, let me emphasize that the annual cap is to help patients who are in need. When it comes to the policy implementation, we keep an application procedure, even though it is non-means tested. That means 7.5 million people of Hong Kong can apply. The application procedure is very simple because the HA already has information about the level of spending of the patient. We aim to take care of patients who are of financial needs. That's why there is the application procedure. For some other patients, they may be staying in hospitals not for treatment or medical reasons. We do not want to encourage people to hog beds. Some patients can be discharged, but for various reasons, they refuse to leave. So we want to make use of this mechanism to have patients who are in genuine need to stay in hospital. The application procedure is very simple. It's not means tested. So once you make the application, then you are eligible. The member talked about patients paying over 10,000. They will be reimbursed. So it's not the case that a late application results in paying more than 10,000. I will defer to Dr. Lee about the implementation details. Thank you. As the Secretary said, not all patients spending over $10,000 will apply. There is a prompt function in our system. If they spend more than $10,000, they may make the application through HAGO or at the hospital. It's very simple, but not all can apply successfully, because for those who have payment in arrears or those who are staying in hospitals not for medical reasons, they will not be, their applications will not be approved. A lot of people actually thank them for prompting them to make the application. So patients don't have to worry. We will prompt them. Any numbers for those spending over 10,000? We have so far approved 3,000 cases. 20% of them have not made any applications.
Thank you, Chairperson. I saw that in paragraph 10 of the document, since the reform had been implemented over the course of 3 months, the hospital authority has approved over 240,000 cases, and more than 19% of the cases have been approved. So it's 16 times more than before the reform was implemented. In the long run, they have the right to be exempted, but a lot of them used to pay, and after the waiver, they do not have to pay, or their costs have been reduced. So under these circumstances, the income from increasing medical fees, is it enough to cover the cost when after we offer the waiver? I would like to know more about this. Also, in paragraph 11, the conditional waiver, applications have been approved, but 60% of them requires a refund. What's the cost? How much will you? What are the resources you need to recover the cost? So whether offering more waivers will reduce our overall income and affect our support for poor, acute, serious, and critical patients, and on our subsidies for medical devices, we will review. We will continue to review. If more people enjoy the waiver, it may affect our subsidies. So I'll give you some numbers. Before the reform, in the HA system, for patients who enjoy full waivers, the three groups of people who enjoy the full waiver and those who can apply for the waiver, among all the services offered by the HA, 20.7 of them enjoy a full waiver. Now it's 27.9%. It's an increase of 6.2%. So this does reduce, this is a reform, but we think this makes sense because those qualified are all those in need. So in contrary, around 72% of the patients need to pay. So I think there's still some room. But later on, we'll do more review on how much resources we can save to help poor, acute, serious, and critical patients. As for conditional waivers, I'll ask Dr. Lee to brief us on that. Thank you, Ms. Chen. So I'll give you some numbers. For the past 6 months, around among the 120 applications approved, 88,000 of them, and then another 35,000 of them have not been reviewed. But we offer them some time to submit the documents, so they have time. We are not worried that they will not submit because they won't be able to enjoy the waivers if they don't submit the documents. And according to past record, we are sure that they will submit the documents on time. Next, Mr. Adrian Pedrojo. I have 2 questions. The NU cap and the subsidies. I would like to know, there are a lot of people struggling in Hong Kong. The middle income families. So does the subsidy system help these families? They are paying more and they enjoy less waivers. Will medical expense make their life harder? And what are the measures that help these middle-income families? And secondly, is there any quantitative measures that tell us how effective these reforms are? For example, the percentage of wastage avoided. So when we do a review next year, are there any data we can refer to? So, Secretary, please. So about the sandwich class, our reform is helpful. So for applicants who apply for the subsidies due to financial difficulties, the number increased drastically. 22 million people are eligible in Hong Kong. This includes those with lower income and in financial difficulties. That means 1 in every 4 people in Hong Kong can apply. For Mr. Ho mentioned sandwich class. We understand that they may face financial hardship due to being ill. So the annual cap of 10,000 will help them. They will not have to worry that if they suffer from serious illness, they will face financial hardship because they have a cap now. So this will help those in the middle class. If they don't have an annual cap, there won't be any upper limit for their medical expenses, and no means test is required, so it can help them. We also relax the threshold for medical device subsidy. Some innovative medicines may be very costly. And through this reform, patients can get more subsidies and their financial pressure can be relieved. As for whether there's any indicator to indicate the effectiveness of our reform, for example, we would like to promote primary health care and also to promote less wastage. These are our policy direction. But we won't set any hard indicators for this reform because there are many factors affecting the effectiveness, so it's hard to say what the objective is. And this is the first phase, I have to emphasize. Our target is to achieve our final objective in 5 years. So we will do a review every 2 years. Next, Mr. Chong Ho-fung. Thank you, Chairperson. Secretary, I have 3 points to raise. Firstly, the distribution of drugs. Before the reform, drugs are delivered at most for 16 weeks and $15 maximum. And now patients ask why they have to pay $20 for 6 weeks medicine. I asked before, you said you would do some reform, and what's the progress and when are you going to implement? And secondly, the objective of the reform is to help patients, poor, acute, serious, and critical patients. And I believe those with special illnesses, rare disease is the target group. I've been following up with the BAH patients, and I went to their briefing last week. They said a new drug has been introduced last week. It's an inhibitor, and it can cure their disease. But it has not been included in the drug formulary. So I know one of the committees will have a meeting today, and I hope that this drug can be included in the safety net. And thirdly, after the reform, you know that the drug formulary, in terms of their support for rare disease patients, how many of them will benefit from the reform? And lastly, in the Financial Committee meeting last April, I asked the Secretary whether the Bureau will allow a co-payment system for patients to receive shots for shingles. I would like to know the progress. Thank you, Secretary. You mentioned 4 weeks as a unit. This actually is a great improvement compared with the past, because in the past it's 16 weeks. There will be a wastage. As for whether there's room for improvement, maybe per week or per day dosage, that per day may be more accurate, to be honest, but it involves a lot of administration process. So you gave an example, 6 weeks. Maybe it can be a benchmark. It can add or it can reduce. So patients can maybe adopt this way of dosage. We will refer to our usual approach, to our set approach, a review every 2 years. If there's emergency, we may review at some point, but for now it's 2 years. As for rare disease patients, I know we understand that they are in real hardship, but then because their diseases are rare, the research and clinical data for these rare diseases are more time consuming. And sometimes because the cases are so rare, it's difficult to know whether the drugs are effective. As for whether PAH or shingles shots, there are a lot of rare diseases. There are a lot of patients with the same concern, and they have different diseases. But these cures and treatments, they are not fit for discussion. The very detailed discussion in the Legislative Council. We need to hand this over to professionals because we adopt an evidence-based approach to evaluate the effectiveness.
Next, Ms. Christine Fong. I am happy to learn about what the Secretary said about the reform. In relation to serious illnesses, say for example those suffering from leukemia, the level of subsidy has increased and they pay less. Those who have the means will be asked to pay. The reform for fees and charges starts at the beginning of this year. I have received some inquiries that when it comes to non-radiology appointments, they will have to pay no less than 14 days before the appointment. Otherwise, their appointment will be cancelled. For MRIs and radiological appointments, you will have to wait for a year or so. If they forget to pay, then they will have to fine the doctor to conduct an assessment, clinical assessment, before they can be referred back into the system. I see that there are prompts in the HA Go. However, we're talking about a waiting time of more than a year for radiological appointments. Will you streamline the procedure? I understand that there is a prompt, but perhaps there can be auto pay by bank, capped at $10,000. Perhaps HAGO can include this function, because after the radiological appointment, they will have to have follow-up appointments in other disciplines as well, so it will have repercussions. When it comes to radiological discipline, I will defer to Dr. Lee. Yes, there are such cases. Well, patients will have to form the habit of making payment 14 days before the appointment, otherwise the appointment will be cancelled. It will come into practice soon. We want to make the appointment for them again as soon as possible if it was cancelled. Our suggestion to patients is that after the consultation, they pay for the radiological appointment in advance. It's the first time that we hear about calls for auto pay. We don't rule that out. We will look into it. In relation to radiological diagnosis and more complex ones, say for example CT scan and MRI, our original intention is to ensure that resources are used properly and there will be no wastage, because there has been cases when patients simply do not show up, so the slot is wasted. As you know that there is a long waiting time for radiological appointments. We have put in place prompts to patients, but still people miss or skip their appointments. We just want to make better use of resources. Any follow-up? No? Mr. Chan Hok-fung. Thank you. The reform sends a shock to society and the community because when people fall ill, they have to go see a doctor. It means that they have no choice but to pay a higher fee. In the system of Hong Kong, if you don't go to the public sector, you go to the private one. I have asked the secretary a number of times if they are aware of the charging situation in the private sector. Will they increase their fees because of the reform of fees and charges in the public sector? Well, the secretary may say that I have not done any scientific research, but what we see is that when fees are increased in the public sector, some patients will switch to the private sector. And if the government is not aware of the charging situation in the private sector, in the end, patients are pushed from the public sector to the private one, and the private sector will increase their fees. I don't know how to conduct surveys, but have you done any to get a better understanding of the impact in terms of cost by patients as a result of the reform? Because this is very important. We have to give citizens a sense of happiness and satisfaction as well as well-being. If they have to pay more, then it will undermine these sense of feel-good factors. Someone asked about radiological appointments or radiological treatments. The HA is aware that there are patients not being on top of their situation. Perhaps there can be a buffer of about 6 to 9 months so that patients can pay afterwards within that buffer. A lot of patients are elderly people. They don't know how to make payment electronically or use HA Go. Even if you ask them to go to the hospital to pay, they can simply forget about it. Perhaps there can be a buffer, say 6 months. Within 6 months, if they pay, then the appointment will be kept. Secretary. We emphasize that this is reform on fees and charges. There will be increase and reduction in fees. Members have been talking about increase in fees, but I've told you about the reductions. 220,000 people have received a waiver. In the past, there were only 14,000. And indeed, 391,000 people within 3 months have used the service. In the past, these people had to pay. Now they don't. We're talking about low-income groups. People with the lowest income level. But if they don't know how to make the application or go through the procedure, please help them, because we're talking about one out of 4 people benefiting from the waiver. The question also asked whether it will trigger an increase in fees in the private sector. We don't have the data because we're talking about a private healthcare market. In the A&E, for the public sector, we have about 2 million attendances. For Cat 1 and 2, patients don't have to pay. We're talking about 10 times more people not having to pay. We're talking about an increase of attendances in A&E that translates to about 200,000. Well, we're talking about a reduction of 10,000 people, 10%, 200,000 people. They go to the private sector. For outpatient services, we're talking about close to 20 million attendances in outpatient services in the private sector. So 200,000 is less than 1%. You can tell from the figures the extent of the impact on the private sector from our reform. We will have more accurate data. We do not regulate the fees at the fee level in the private sector. We want to increase transparency in the private sector so that they know who has hike fees. In relation to the buffer or the transition period, I'll defer to Dr. Lee. I thank Mr. Chen for his suggestion. The change in fees starts on the 1st of January. When it comes to radiological appointments, there is a buffer. The fee paying mechanism is started on the 1st of April. And indeed, there are people who did not pay. But we monitor the situation. We check whether appointments in the coming 14 days have been paid or not. If not, the patients will receive a call. There is a buffer of 14 days. And we remind patients, even if they forget to pay, we have arrangements for them to have an earlier date fixed if they arrive for the appointment on that day. So the patients are advised to pay for 2 weeks before the appointment. Professor Cheung Wing-kwong. From the data supplied by the government, we see that the number of attendances at A&E as well as waiting time have registered a drop. However, public healthcare sector is the safety net for all. We can't just think that the reform has achieved success because of a drop in attendances as well as a drop in fees. In paragraph 16 of the paper, it says that in the first 3 months, the number of attendances at A&E has dropped by 10%. Has the government conducted any analysis as to the reason why people have not visited the A&E? Where did they go? Did they go to a private clinic? Or they just purchase over-the-counter medication because of the increase in fees, or simply not go? Paragraph 32 of the paper talked about patients taking initiative in reviewing their medication needs. In the first 3 months compared to the same period last year, there has been a drop in demand for medication by about 7%. So how does the government ensure that a reduction in demand for medication will not hamper treatment progress? And I'd also like to ask about the overall revenue of the HA. Has it increased compared to the same time last year? With the reform, there has been an increase in number of waivers approved. Will it offset the increase in fees? How do you ensure that the reform will improve the sustainability of our public healthcare sector? Secretary, in relation to a drop in number of attendances at the A&E, the figures have spoken very clearly. We're not talking about Cat 1 and 2 patients. Their number remain the same. And the fees are waived. It shows that for those who are in genuine need, we will take care of them free of charge. The drop are among Cat 4 and Cat 5 patients. Majority of them are suffering from a mild condition. They didn't have to go to the A&E, and they did not need immediate treatment. There's a mechanism for refund. If they are triaged as, say, Cat 5, then they could choose to pay. as to whether they have other options. But for some patients, they are just suffering from a mild fever or headache or itchiness. There are many different ways to treat these symptoms. They can use medication themselves, or they can wait for the next day, or they can go to a private clinic. We don't have the statistics because they simply did not show up. All we know are that these patients are suffering from mild conditions, not critical or emergency cases. And this group is the ones that we want to remove from our public, remove from our A&E system, because they will increase the burden. In relation to reduction in medication supplied, there are people saying that there is a serious medication wastage. Some have been resold in an underground market. We have registered a drop by 43% in terms of constipation drugs. We have seen the medication being sold in a secondary market. We don't want medications to be wasted, and we want it to be used properly. As to the use of fees we have collected, we want to use the additional fees received for the poor, acute, serious, and critical patients. We see that our support to them has increased from 20.9% to 27.9%. 70% of the patients are fee-paying. We do think that the reform will give us the capacity to divert resources to help those who are poor, suffering from acute, serious, or critical illnesses. Dr. Ben Chan, expenditure in the healthcare sector reaches the tune of hundreds of thousands of billions of dollars. This is a heavy burden. We need to have repeated discussions, in-depth discussions when it comes to reform. It was only until a reform was floated that we had a chance to ask questions and had discussions. We have raised issues that should have been discussed before the reform. We felt that we did not have a platform or chance to talk about them or express our views, which is not ideal. We could have done a lot better in this regard. Now fees have increased. The Secretary on different occasions has given us figures and talked about a large increase in number of beneficiaries. But now let's look at figures. In the past, fees were affordable. That's why people did not have to make applications for waivers. With the increase in fees, more people apply for fee waivers, hence an increased number of approved applications. You use the new figure to show the effectiveness of the reform. I think it's a wrong comparison. Perhaps, Secretary, you should mull over it to see if there are other ways to show the effectiveness of the reform. Don't tell us the number of beneficiaries, because in the past, people could afford the fees, but not anymore. No one want to air dirty laundry in public. And yes, indeed, you have shown us well, I understand that you require supporting documents before you approve applications for waiver. But I have some questions. A ripple effect. Health Healthcare fees and charges is close to the heart of a lot of people. The reform has caused a ripple effect. People are concerned whether the fees in the private sector will increase, whether there will be an increased fees in specialist, outpatient, services, outpatient services, etc. Has the government conducted any study as to the fee charging situation in the private sector as a result of the reform? If they have the figures, please let me know. If not, then please conduct the survey.
And after the fee increase, we have more income. So how will the government use the extra income onto the patients? For example, for those with long-time illnesses, chronic illnesses, and also A&E fees have increased. If you have a fever at night, will there be any evening outpatient services? How will the government use the extra income? Thank you. Discussion on our fee reform have already been conducted multiple times in the LegCo. We will continue to listen to different opinions at suitable times. Our fee reform is not a one-time project. We have a 5-year plan, and it will be reviewed every 2 years until we reach our final objective. As for what you mentioned, exposing your personal details, making the application. Medical expense is a huge burden on government finance. So if we don't do reform, then we are doomed to death. We have to shoulder the responsibility. As for subsidy application, those are public money, I have to emphasize. Those who do not meet the eligibility criteria, we have to handle them very seriously. I would like to tell Dr. Chan that there's a case. A citizen has $4 million of assets, and they apply for subsidies. Is it fair to taxpayers? Secretary, this is not what I mean. You give me these numbers, but my question is, maybe Secretary, you didn't understand well. What I said was the numbers, the statistics before the reform compared with the statistics after the reform, they may not be comparable because some of them may not apply for a subsidy before the reform. And some of them apply for the subsidy after this. So I mean that these statistics may not be comparable. Of course, the statistics compare pre and post reform. I emphasized that 391,000 patients enjoy the full waiver. They do not have to pay now. In the past, it's only $50. Everyone can afford. Please let the Secretary finish. I would like to finish first, please. They did not have to pay. They may have to pay partially, but they don't have to pay now. I would like to emphasize that those are marginal groups of people. I've also addressed that for the $3 billion issue, we may be able to help them. More people are eligible for the waiver. The 10,000 cap will help the middle class. Cat 1 and 2 patients do not have to pay, and there will be more subsidies for medical devices and drugs. And evening outpatient service, we have a plan. We have already briefed that we will increase the number of outpatient service. We'll add more outpatient services, and there will be more quota in Q2. We will target at areas with higher demand for evening out patient services. Next, Ms. Chan Ho-yan. With the aging problem, I support a medical fee reform conducted in an orderly manner and have consulted the public. I would like the government to talk about items that require a fee increase, but these items have not consulted the Legislative Council, and there's no deliberation on these. These items were only informed by the government to the council. So what we see, one of the issues is the SOP clinic. It used to be $80, but now it's $200. It's a 3-time increase. And also, there's a fee increase of 4 to 5 times in the medical fee, and a lot of our citizens do not support the increase. And also in paragraph 7, later on this year, the phase 2 will roll out. So I would like to ask, we now demand that the implementation of fee reform in 2028 should be discussed in the LegCo before being rolled out. I would like to ask the government to do that. Thirdly, patients who have specialist diseases have their own needs. I would like to use this platform to ask the HA to explain why the fee increase for SOP clinics are so drastic. Thirdly, it's mentioned that 1 every 4 person will enjoy the waiver. But Dr. Ben Chen said that it was cheaper before, but it's less affordable now. So more applications, there are more applications for subsidies. So it doesn't mean the reform is effective, but in my office, 2 out of maybe 4 cases, maybe you think it's unscientific, but 2 out of 4 cases are dissatisfied about the reform. So I would like to ask the HA, would you set up a hotline for those who are affected by the reform to compile statistics about who's affected and very unhappy about the reform? Let's see what the hotline what complaints the hotline will receive, and see if we can study whether our citizens are happy about the reform. And additionally, in the special council meeting of the FC, the government provided data about patients not collecting their medicine, and the reason is because the patients do not really need the medicine, and the patients confirm that they do not need the drugs after checking how much drugs they have. So I would like to know whether those drugs that will be wasted can be listed on their medical form. There are a lot of questions, Chairperson. I'll try to address all of them. According to the HA ordinance, we will also gazette the reform. We also gazetted the reform. We have also been briefing the council. We have no intention to amend the HA ordinance about the fee reform. Ms. Chan also said the patients have no choice, so SOP clinics should be kept at a very low fee. Now, I need to clarify, I did not say very cheap. I did not say very low cost. What I understood is to keep the fee low, like in the past. In my opinion, SOP clinics charge was too low. Some patients didn't value the service. It's the service of our professional medical practitioners. We want to remind them to value our resources, because there was resources misuse. And this is one of our primary focuses, developing the primary health. Some more simpler issues can be treated by GPs indeed. I would like the fees to reflect the value of professional services. As for the hotline service, I'll give the floor to Dr. Lee. Thank you, Secretary. I'm aware that each answer should be 4 minutes. I'll try to simplify. As for the hotline service, the HA has been collecting views and feedback through multiple channels. Apart from consulting and meeting with patient organizations, we also receive letters from patients. We believe that these are very objective ways to collect opinions. Some of them reflect that they would like to have waivers and subsidies. According to what we have heard, they understand why a reform is necessary. So we will continue to use these channels to collect opinions, and we also encourage citizens to voice out. Ms. Chen would also like to know that how many patients have not collected their medicine. I believe that there are multiple statistics we can refer to. A prescription may list multiple drugs. For example, some necessary drugs like constipation or headache drugs, and sometimes it may be a one-off drug. We need to look into what are the drugs uncollected. I would like to give you the numbers in the past 4 months. We had 35,000 prescriptions, and 97,000 of the drugs have not been collected. And before it was more. Actually, the number reduced by 5%. So Ms. Chen also said if we can do it prescription by prescription, it's not actually for collecting fees, it's actually for doctor's reference. Why do doctors need to know that? Because there were multiple cases when drugs were not collected and have not been prescribed in the next consultation. So if for medical staff, they can refer to the prescription to know which drugs have not been collected but the patients may need next time. Sometimes patients may lose their medicine, and if they if there isn't any mention on the prescription, then we won't be able to give them medicines next time. So it's a case-by-case basis.
喺第7點嗰度，
May I have it recorded that in relation to point 7, the Secretary said that, well, the LegCo cannot negative proposed increase. And here it says that in the paper that the proposal will first go through LegCo for our discussion, even though we did not, even though we do not have the right to veto it. I want it recorded. Yes. Reverend Peter Kuhn, please. We'll draw a line after he's spoken. I understand that Hong Kong is unique. There are no other places like Hong Kong that patients don't have to pay extra to receive quality service. However, we have an aging population. The burden in the healthcare sector will increase. It is our policy objective to maintain the quality of service in our public health care. I do realize that there is a significant expenditure on healthcare and there are greater challenges from an aging population. Some members of this council and of the public understand that there is a need for reform. However, when it comes to a significant increase in percentage of fees, there will be strong voices. Does the government have any ways to explain the situation better to the general public? I understand that without the reform, the system will implode. It is not sustainable to keep asking for an increasing funding support. It's not the case that one side is louder than the other. I just want to hear from the Secretary as to whether there are other ways to help stakeholders understand. Perhaps we will hear from the Secretary first. We have done a lot of work to explain about the reform. Other than the Health Bureau, there are other parties involved. We have explained to district councillors. We have organized over 100 briefing sessions by the Bureau. Well, members talked about the extent or the magnitude of the reform, but I would like to talk about the magnitude of the fees. In the past, the fees were set at too low a level. It was patients pay only 2.4% of cost. So you may think that it was a major change. Our level of subsidy was 97.6%. We now in the first stage aim at 95%. So a drop by about 2.6%, which is mild. Given the high level of subsidy, we are only reducing it by 2.6%. That is something that members should understand. Any follow-up? Next, Mr. Kingsley Wong. The Bureau has heard a lot of views. They have streamlined certain procedures. There are 6 arrangements. Say, for example, relaxing the definition of household or family. Co-living family members with no significant financial ties will be excluded. And for supplying information, there is a drop-in box. That's a paragraph 13. However, there are still complaints about the complicated application procedures, and different hospitals have different arrangements. Have you standardized the practice of different hospitals? My second point is about the increase in fees under the reform. Some people think that if they ask for an extension for a postponement of their follow-up, then they needed more medication. In the past, they charge only about $50, but now they will be paying a lot more, $270 maybe, without seeing a doctor. They would be unhappy because previously they paid $90 and now they have to pay $270. Is there any room for reduction? Well, they will feel that it's reasonable if they have seen a doctor. Perhaps you will reduce the fees by half and just charge them less. I'll defer to Dr. Lee. Mr. Wong is right. We have simplified and standardized the application procedure. So when it comes to applications for waiver, about 90% of the applications were dealt with on the same day to help those who are in need. In relation to medication fees for SOPC, I think the $250 will be waived without seeing a doctor. I think you will. Well, patients are only charged for medication. Perhaps I will talk to you after the meeting to see if there are cases when patients are charged $270 without seeing a doctor. This is an actual case. The patient was charged $270 simply for getting the medication. Well, we'll talk to you after the meeting. Thank you. Next, Mr. Peter Shiu. I see in the PowerPoint, the second slide, it talked about acute cases, that is in relation to A&E department for Cat 1, Cat 2, and categories 3, 4, and 5, namely critical, emergency, urgent, semi-urgent, and non-urgent. It says that since January 2026 with the reform, there are changes in the figures. For Cat 1 and 2, there has been an increase in demand for about 3%. For categories 3 to 5, the demand has dropped by 10%. Well, that's the original intent of the reform. In the past, people went to the A&E for mild conditions, say for example just a flu or a cold. As a result, those who are in genuine need of A&E service would have to wait longer. We see a change in just 3 months. Is it something you expected? Are you satisfied? If not, what more can you do? Secretary. We did not set hard indicators for the effectiveness of the reform, say for example reduction of a certain number of attendances. A&E is an important part, but it's still only one part of our reform. The outcome is in line with our expectation and the direction of the reform. And as to the extent, whether it is sufficient, we see that for Cat 4 and 5 patients, they still account for about 50% of the attendances, which is quite high. Is there room for further reduction? We will look into it. And this is just the figure for the first 3 or 4 months. We will keep it in view. perhaps the number will rebound in relation to the number of attendances for Cat 4 and 5 patients. We will carefully monitor the situation to see if there is a need for changes in our strategy. So, Secretary, you mean that you did not expect to divert resources to help more Cat 1 and 2 patients, and for Cat 3, 4, 5 patients, and you just leave the decision to themselves and the market? Or is it the case that the design of your reform is to help Cat 1 and 2 patients, and for Cat 3, 4, 5 patients, you hope that they will go to the private market? You just want, well, but what about an indicator? Not a hard and fast one, say 7%, but still, there is an indicator, but with some flexibility. I think what the Secretary meant to say is that for the percent he would hope that the percentage of Cat 4 and 5 will drop. The A&E department operates round the clock. Anyone who wishes to use the service can make a registration. It is a choice of the patient. We hope to enable the A&E to divert resources to help critical and emergent patients of critical and emergency cases. We don't want the treatment of those who are in genuine need to be undermined. With a reduction in Cat 4 and 5 patients, we hope that for Cat 1 and 2 patients, say for example those suffering from a stroke or chest pain, the procedure could be streamlined so that they can focus on services provided via chest pain centers and stroke centers. We want to reduce the number of mild cases. We want to trigger a change in behavior and an increased understanding on the part of patients that they can go to other places, say for example the private sector, to have their cases looked at.
The Secretary is playing safe, but actually everyone knows that the A&E reform aims at letting those with less emergency seek other services. And for drug wastage, not a lot of people agree with that, but we see that the reform is actually effective in reducing these wastages. So I support this reform. So not like my other colleagues, I'm standing with the Bureau this time. All of us love our country, and we may not always agree or always disagree. I hope that we can communicate with the administration in a friendly manner. Next, Mr. Yang Wing-kwat. I understand the overall reform of the public medical system. I understand that if there's no reform, then there will be a lot of expenditure. The Secretary mentioned that the subsidization rate is already high, but have you considered what's the cost? If the cost increases, then the subsidization rate increases. That's the logic. If you keep raising the cost, no matter how much you subsidize, the ratio is low. So, Secretary, would you please explain, will there be any reform on cost-saving measures, so it won't create an impression that the government is seeking money from citizens? This reform has beneficiaries, but some are also negatively impacted. So those who are happy also wants the government to improve, to do more. Those who are benefited they pay less now, but they also would like to know whether there's an automatic waiver system. Some of them are eligible, but you still need them to run through the whole process. And the other one is elderly living allowance. Will it be possible for the administration to consider these group of people? I know it won't involve a lot of costs. The secretary may say it's not possible now, but how about the next phase? Also, for those who are not benefited, Monday when I was in the community, a lady approached me and said she's not eligible for OLA and the OLA, but she never reaches the 10,000 cap. Maybe like a few months, 3,000. It's around 10,000, but did not exceed the limit. Most of them can't reach the limit. For this group of people, their cost is higher now. So I would like to know that in order to increase the sense of happiness and well-being for these group of people, some of them are very happy. They can purchase medical insurances, but then some of them can't do that. Mainland residents are very happy now. So I wonder if we can help those marginal groups. It's actually a large group, maybe thousands or millions of people. Will there be ways to help them? Accept the waiver? Is there any mechanism to help them? Those not included in the beneficiaries, they have to pay a lot for medical fees. Will there be ways to help them? Those with a lot of asset, we are now putting them out of the equation. So, Secretary, please, for the reform, it's very important, the cost controlling aspect of the reform. But the greatest cost for medical fees is manpower. Our medical profession actually does not incur a lot of expenditure. There are only 2.2 doctors in 1,000 people. It's actually a low number. So it's only a small group of people taking care of 90% of our citizens. So that's why we hope we can attract more talents, and therefore there will be a higher cost. Also, innovative drugs and medical devices are very expensive. Targeted therapy for cancer patients are effective, but it's very expensive. It costs 500,000 per year. We would like to find the most advanced therapies for patients, and we are setting up a center. This will also incur more cost. In the past, a stroke center. In the past, for stroke patients, maybe you are partially paralyzed. We could just help you restore mobility. But now with the stroke center, maybe we can fully treat the patient. This requires money, and therefore reform is necessary so that we can have more income to support more patients. As for means tests, can we adopt other standards? The reform is for those with financial difficulties. So it's not like any OLA. So the safest way, we believe, is to conduct means tests. And then the other question about medical insurance in mainland China. It is improving in mainland China, but it's a bit different in Hong Kong. We have a very excellent system. We have low tax rate, and we don't have to pay medical insurance contribution each month. It's not compulsory. You can just use your HKID and go into hospitals, and the government will subsidize you to gain access to medical services. I think for mainland China, it's $800 each month for employers in terms of medical insurance, and it's a lot of money in a year. There's a reimbursement system, but it's still a lot of money. It's actually quite hard to find a place with 97.6 of subsidization rate. So my core question is not about medical insurance. I'm asking whether you would think about ways to help these people. The marginal groups, they face a lot of cost, and it's a huge burden on them. This is my core question. This is an excellent question. So what we need to consider is to consider your health when you're young. How are you going to handle medical fees when I'm old, when I age? So we will review our reform. The VHIS users are increasing, and we need to review that, of course. Next, Ms. Jovi Chen. After the implementation of the reform, the focus has been on outpatient and A&E services. For drug fees, it's charged not per consultation, but every 4 weeks. It's a lot of cost for the government, and 5 times more than before. I think it incurs more cost than other. It's a higher increase than other items, and some users tell me that they are shocked when they see the invoice. I have heard that from multiple elderly people. And how are you going to help them? And secondly, patient advisory groups and rare diseases groups submitted their opinions. And everyone knows that cancer drugs and therapies for rare diseases are very expensive. The review mechanism will be conducted every 2 years, but it's not good enough. So will the 1+ mechanism be able to alleviate the situation? As for whether we can help those with chronic diseases, I won't recap, because if they belong to low-income group, then they can apply for subsidies. Our eligibility criteria have also been relaxed so that more people can be benefited, so that 1 out of 4 people can be benefited. As for those who are not eligible, the 10,000 cap can help them. We will continue to review the system, and we would also like to emphasize that this reform there will be cost increase and reduction. So as for whether there's room for review, then we will look into it regularly. As for including in the drug formulary, there are more and more innovative drugs now. For drugs for rare diseases, they do not have enough clinical data, and they're also very expensive, but HA will actively assess whether these drugs are effective to patients. They need to consider many factors apart from the cost. They also need to consider whether there are alternatives, whether there are similar drugs, whether it's a first-in-kind drug, which means that it's the only drug that can save the patient. One example, a genetic therapy drug which treats a very serious neuro disease. It has been included inside the safety net. One shot costs over $10 million. It's an impressive number. Just one drug costs $40 million. So we have to be very careful. After the reform, I think we have more room to consider these drugs, and more patients may be able to use the service.
I'm glad to hear from the Secretary that the unit, the charging for medication may be changed. Perhaps before the review, they can come to LegCo to collect our views, unlike what they did in the reform. We will maintain communications with the administration and the Health Bureau. Next, Ms. Grace Chan. I would like to respond to what the Secretary said in his reply. In the last slide, it talks about 11 drugs being added to the drug formulary. Does it include a certain illness? Let's look at the written question on the 15th of October last year. It talked about the need of this group of patients. We understand that a process will have to be followed for a drug to be enlisted. There are 160 sufferers of these diseases. Only 30 of them belong to the age group of 0 to 3. Patients have to go through a series of surgeries. They have to stay off school. The road for them is bumpy. So will you carefully consider this rare disease, which is achondroplasia? I understand that starting from the end of 2024, they have started a new exercise. They have put in a lot of effort, and they have given us their undertaking. So if more can be done for medication and rare diseases, perhaps it will bring actual benefit to those suffering from rare diseases. There is rapid development for innovative drugs. If we do not introduce a reform, we will lag behind. If we are to become healthcare innovative hub, we need to use innovative drugs as soon as possible. For each drug, there are many different considerations. We need experts to consider whether the drug is cost-effective using a medical evidence-based method. In relation to the drug you mentioned, I will defer to Dr. Wang Yu-chung, Director of the Hospital Authority, because there are many different types of diseases and drugs. When it comes to enlisting a new drug in the safety net or the drug formulary, there is an established procedure. In 2024, we started an exercise to improve the process. Every year, we see a larger number of drugs included. We have also enlisted more experts to help. There are 21 expert panels. Other than looking at the efficacy and safety of each drug, we draw reference from other places' practice. Say, for example, when it comes to drugs for rare diseases, we look at the use of medication application, the management protocol. We conduct an assessment for each drug. If there is insufficient information, we will ask pharmaceutical companies to supply further information. That's why we need more than one meeting to handle the application of a drug. There will be further discussions. It's not possible to make a quick decision for each drug. I am the next person to ask question. I support the direction of the reform. We need to use finite resources and focus the resources on those who are in most need. We talk about rare drugs for rare diseases as well as cancer, and the enlistment of these drugs into the drug formulary. I understand that the hospital authority has improved the vetting procedure as well as speed in the enlistment. Some people see that the drug they need is on the formulary, but they don't know how long they will have to wait. Will the hospital authority consider compiling a list, setting out the type of drugs, the time required for approval, say for example the 90% percentile, the median time, etc.? I'll defer to Dr. Wong. Thank you. We follow our procedures step by step. When the Drug Advisory Committee conduct a meeting, it will be done once every 3 months, and for each meeting we cover about 20 to 30 drugs. If there is sufficient information and if we have had discussion with clinical experts saying that it's possible to use the drug. Please understand that it's not just about oral consumption, oral intake, or intravenous use. Sometimes we need to have a dedicated team to consider different factors. We try to speed up the process as soon as possible. When there is insufficient information, we'll follow up with the pharmaceutical company or the manufacturer. We need to consider whether the drug is suitable or whether the drug is already on the drug formulary. Then we will give it a lower priority. In the meantime, we will talk to the pharmaceutical company on, say, cost effectiveness. For example, better terms. And these are outstanding matters to be followed up in subsequent meetings. Usually in the second or the third meeting, we will conclude our discussions. And as to whether we will show 50% percentile or 90% percentile to present information about our discussion, that may not be suitable because for some drugs it may require a longer discussion. So it's not appropriate for us to say at which stage our discussions are. We will try to keep transparency. We provide information on our website about the process of discussions as well as the stages. Thank you. That's the end of this item. Item 4, implementation of the advanced decision on life-sustaining treatment ordinance. We will invite the administration to come in to join us. We have from the government Professor Lo Chong Mao, Secretary for Health. Principal Assistant Secretary for Health, Mr. Leo Lee. Dr. Doris Che, Consultant at Caritas Medical Center. Dr. Raymond Chung, Chief Manager, Hospital Authority. Ms. Jenny Yan, Assistant Director, Social Welfare Department. Ms. Olivia Yip, Chief Social Work Officer, Social Welfare Department, and Dr. Maria Leung, Chief Manager of the Hospital Authority. Question and answer 4 minutes for this item. This is related to a legislative proposal. Non-panel members are invited to participate. Those who wish to speak, please press the request to speak button. We'll now hear a presentation of the paper from the government. Chairman, it is a process of life from birth to death. Our aim is to ensure suitable end-of-life care services for terminally ill patients so that they can complete their lives with dignity. In November 2024, the Advanced Decision on Life-Sustaining Treatment Ordinance was endorsed by the LegCo. It was a policy aimed to put in place relevant measures. This is a step forward. There are a number of measures. First, advanced medical directives, AMDs, and do not attempt cardiopulmonary resuscitation orders, DNA CPR orders, as well as suitable life advanced care planning, ACP. We want to enable adult patients, when they're still mentally capable, to make plans to give advanced directives to decide what treatment, life-sustaining treatment, to be refused. The order will be made by registered medical practitioners for the patient's best interest. Under specified circumstances, CPR would not be done. There is a principle of cautious making, easy revoking. It has to be cautious when the making of it, to ensure that the patient will make an informed decision after having fully understood and carefully weighed the implications, having consulted their family members. Healthy patients will find it difficult to decide on what treatments they need, so it is not appropriate to make decisions too early to cater for unknown terminal illnesses. There is a stringent requirements when it comes to issuing of the orders and the directives. When it comes to easy revoking, we make it easy for patients to revoke the arrangements. We want to clearly regulate the duties and legal liabilities of medical practitioners. The medical practitioners will follow the orders and not conduct resuscitation. However, when they are in doubt, they will save life first. The medical practitioners and rescuers are absolved of legal liabilities and duties. We want to do it in an electronic way. By stages, we will incorporate the directive and forms in electronic copy. Patients may decide themselves whether to have an electronic copy stored. When certain functions are put in place in e-health, we will have electronic directives stored. Practitioners can access the e-health. When it comes to the AMD, the directives, however, regarding the do not attempt CPR orders, given the limitations, it will only be in paper form. There will be no electronic form. With the passage of the bill in 2024, we have liaised with different groups for preparation. There are 4 major areas. First, to provide guidelines and trainings for certain personnel. The hospital authority has provided briefing sessions on the legal framework as well as guidelines. Relevant bodies have also provided guidelines and trainings. We also aim to enhance the system. We want to, by stages, allow patients to store, revoke, and access the electronic directives. We have liaised with relevant professional groups in relation to their systems. Public education. We want to enable practitioners and professionals to start discussions at appropriate times and reach consensus in the end. The passage of the bill gives us an opportunity for us to have an in-depth discussion about the advanced care planning as well as the advanced directives. We have worked with NGOs as well as the Jockey Club organization, the Jockey Club End of Life Community Care Project, to provide information to those in need for making preparations in the right time. Transitional arrangement. Valid directives will continue to be valid without having been renewed. However, the orders will have to be reissued for it to be effective after the commencement of the ordinance. We issue new orders using the prescribed form or issue new orders using the prescribed form before the commencement of the commencement of the bill. We also remind practitioners in the private sector about the arrangements. Everything is ready. We will, by notice in Gazette, appoint the 31st of July 2026 as the commencement date of the ordinance. This marks a milestone of the implementation of these advanced directives. This also offers a protection to registered professionals. We will enhance public education, training, so that patients will be able to reach the end of their lives with dignity, and support will be given to family members as well. Thank you, members. I will read out the names of members who are waiting to speak. Ms. Christine Fong, Mr. Mark Chong, Professor Chen Wing-kwong, Ms. Jovi Chan, Ms. Rebecca Chan, Ms. Grace Chan, Ms. Reverend Peter Kuhn, and Mr. Peter Shiu. 4 minutes answers and questions included.
Thank you, Chairperson. The government will implement the ordinance will come into force this July. So that patients through AMDs and DNA CPR orders, they can choose whether they will continue to live. And I'm in strong support for this ordinance. I think it's necessary, but then I have 3 concerns. Firstly, when the ordinance becomes effective, what are the measures to enhance frontline medical professionals, and what are the measures to enhance public education? As mentioned, we should save lives first. So not only about medical professionals, how about some rescuers, lifesavers? If they run into someone who needs rescuing, what should they do? When they meet someone with a DNA CPR order, what should they do? So this can help protect the lifesavers. Also, in the past 18 years, I've provided a free will setting service and a 3 instruments of peace setting up service for the community. So I would like to ask whether the administration can work with community networks such as the care teams to provide more support services. Also, according to the JC End of Life Community Care Project, it covers 38% of the demand in Hong Kong, including cancer patients. It's 79% of coverage. For non-cancer patients, it only covers 1.4%. Can there be more support for these patients? Secretary, please. Thank you. About life and death education. It's very important, of course. We need discussion on that. We also hope that life and death education will not only be available in the final stage of our lives. We will roll out our public education program. Indeed, it has already been enforced in different levels, including elderly service, and also in medical organizations, also in schools as well. For example, as mentioned, the JC End of Life Community Care Project, we work with the HKU Faculty of Social Science. They held different talks and seminars. And there's also an outreach team offering nurse consultation for patients. The government healthcare services held around 2,000 talks. Also, the HA Patient Resource Center organized different life and death education talks for members of the public as well. There are trainings offered to care homes so that staff will know how to support elderly people with EOL needs and their family members as well. Also the lifesavers, they must adopt the if in doubt, save life first principle. But we still hope that with the legal basis established, these lifesavers, if they see a DNA CPR order, they will understand that this document issued by medical professional will change their decision, and they may want to help the patient, but the patients may not be able to live in peace. As for how HA will train their staff, I would like to invite Dr. Chung Wai-man, our Chief Manager in Patient Safety and Risk Management, to talk about that. Thank you, Dr. Low. In our planning of the ordinance and our final preparation stage, HA has organized various staff training forums to brief them about the ordinance, including the extent of AMDs and DNA CPR orders. Of course, under the legal framework, our framework also told our colleagues what they need to pay attention to. And we also offer courses for them, some online courses for them to enroll to enhance their understanding and how the ordinance will affect their daily routine. Next, Mr. Chong Ho-fung. Thank you, Chairperson. I met with some patient advisory organizations, and they have three concerns. Firstly, about the AMD. So one of the witnesses must be a registered medical professional, but actually each doctor meets patients for maybe like few minutes. So patients don't really know how to tell doctors they want to set up the AMD. And some medical staff, they may be too busy to really help patients to undergo the entire process. Some cases waited for 3 years to sign the AMD. So some patients who deteriorate drastically could not sign the directive. So in the public healthcare system or in community centers, will there be some slots for patients to sign the directive, the forms? And secondly, I would like to ask about some public education campaigns. The medical professionals are very busy. They don't have time to sit down and explain the procedures. Will there be more talks or activities in community centers about life and death education? And in paragraph 18, 14 talks have been organized by the HA. According to the number provided by the HA, there are 37 and 400 medical staffs, and so not all medical staff have been trained, but everybody faces life and death situations every day. So will there be any improvement? Secretary, please. Regarding AMDs, it has been mentioned that we adopt a caution-making, easy revoking principle. Caution-making is very important. The patient, if in a certain medical condition, they don't know how their illness will develop, and they are not sure whether the life-sustaining measure can help them, it's actually quite dangerous to set up the directive. Therefore, a doctor must be present to ensure that the patient knows what they're doing. And therefore, the directive must be signed by a doctor, a registered medical practitioner. These patients are not in GP. Most of them are in a terminally ill situation, and they are approaching the end of their lives. And the HA pays great emphasis to them. So some specialist clinics, they will offer special arrangements for them, and medical practitioners can brief patients on the procedure. As for community centers, district health centers, I don't think it's very appropriate because it's not for clinical procedure. If specialists visit the centers and brief patients, I don't think it's cost effective. As for HA training, I'll pass the time to Mr. Raymond Chang-wai. Dr. Zhang, please. For staff training, in our forums, around 10,000 of our staff attended. Apart from the forums, we also offered online courses. Over 20,000 of our staff have enrolled. Our online training will be offered. It's an ongoing process, and it's not a one-off course, to ensure that staff have enough knowledge. What I meant was, in these community health centers, will there be a designated time slot for specialists to visit the centers? Because a registered medical professional must be present. Maybe they can spend an hour or 2 hours in these centers to help sign the directives for these patients. And also, I think community health centers are for primary healthcare purposes. Actually, the medical history of the patient is very important. It's very important to refer to their medical record. So it's important that the doctor who has been following up with his or her case be present. If there's no medical record, then it's no point having the doctor there.
Professor Wong, Deputy Chair, I'm very happy to see that the ordinance will commence in July this year. I hope that it would enable those who are terminally ill to make better plans for the end of life care and treatment, and that their wishes will be respected and implemented. According to the information paper, the advanced care planning is in certain departments of the hospital authority. Say, for example, the geriatrics department. There will be an increase in the number of directives. As you know that there is a manpower crunch in the public sector. I want to ask, what about the situation of practitioners in the private sector? Will there be measures put in place to encourage practitioners in the private sector to make arrangements for patients to sign the advance directives so that there would be better promotion of the advance directives, enabling more people to make advance plans? Secretary, whether it is the advance medical directives or do not attempt CPR orders, that is not exclusively for the HA to do. From housemen, interns, in-house training, we have put in place different avenues for training. Before the ordinance, we use common law practice to do it. Whether it is the directive or the order, they can be put in place in the private and the public sector. Our training don't just focus on the public sector. The Hong Kong Academy of Medicine in April 2024 issued best practice for private practitioners. The 17,000 doctors in the private sector receive the best practice trainings to enable them to better understand the arrangements. I think it will be implemented territory-wide. Next, Ms. Jovi Chan. To ensure smooth implementation of the ordinance, Mr. Bill Tang and I, and as well as some patients groups, have sent letters. We want to enhance education and consultation with patients and their carers. During the 18-month period, the Health Bureau has conducted trainings. I want to ask whether the government will start with the community first and put in place accreditation courses for end-of-life planners. How can the government ensure that registered Chinese medicine practitioners and practitioners in the private sector will know what to do to fill in the prescribed form of AMD as well as DNA CPR orders? The directives and the orders have been covered in promotion in the private and public sector even before the passage of the bill. It's just that in the past that there was no clear legal framework and protection. There are more cases in certain disciplines, say for example oncology, geriatrics, as well as care and palliative care. The Community Geriatric Assessment Team of the HA reach out to residents in RCHEs to take care of them. So they're quite familiar with the concept. The hospital authority will continue to incorporate the directives and orders in the care of patients of advanced illnesses. We will aim at enhancing understanding as well. As I said, last year, the Academy of Medicine have issued a best practice guidelines for all doctors in Hong Kong. Next, Ms. Rebecca Chan. There will be a legal framework put in place for advanced medical directives and do not attempt CPR orders. I support the measure. I am concerned about administrative operation. We don't want anything unpleasant to happen. I have received some calls for assistance and I reach out to certain hospitals. There was this patient staying in a hospital before they died. They have specified a wish to not resuscitate. However, when there was a change of hospital, family members might think that the other hospital will have a different arrangement or better treatment in place. As a result, they thought that the directive might change. So I think it's a matter of understanding of the different arrangements. They wonder whether with a change of hospital, the directives and the orders will still be effective or valid. The ordinance has clarified the legal aspect. But what about administration? Will there be further measures to protect families and patients? After a change of hospitals, will there be a reminder sent to them? When it comes to life and death education as well as advanced care planning, the general public might not have a clear idea of what they're about. What will be the key areas of work of the hospital authority or the Department of Health? Will there be further efforts put in to explain these aspects? Will you do more work in oncology as well as geriatrics department? The do not attempt CPR orders in the past was confined within the hospital setting. Once the patient has left the hospital, the order will not leave the hospital with the patient. However, now the order will follow the patient. The order will be in paper form carried by the patient. Patient in the hospital authority will have the order put in a special pouch. Patient might pass away in a different hospital or outside a hospital. The order will be carried by the patient. When it comes to implementation details by the hospital authority as well as publicity, perhaps I will defer to Dr. Doris Chair of the Caritas Medical Center. Dr. Chair, other than guidelines, the hospital authority also set down flow chart of how the staff will handle these cases. When the patient arrives at the hospital and when there is the order available, staff members will arrange for the directives and orders to be clearly stated in the medical chart of the patient. Hospital staff should also reconfirm with the patient whether there is a change of heart. In relation to inpatient, we would like the recipient hospital to confirm again whether the patient has not changed the directives. We want to put in place a workflow to prevent any change or misunderstanding when there is a change of hospital. Next, Ms. Grace Chan. Thank you. The administration has talked about training and guidelines. I want to move to a different area. When it comes to rare diseases, patients and their carers encounter difficulties. It's not easy for them to complete the procedure. They told us that in August 2024, they arranged with the HA to talk about their difficulties. Perhaps you can arrange with them to see if the difficulties have been overcome. Please enhance communication. Regarding public education, patients would like to have enhanced public education so that their family members will not become obstacles. I don't really understand what difficulties patients encounter. I think she meant difficulties in conveying their wishes. There was a meeting in 2024. The advanced medical directives have to be made when the patient is still lucid. There will be a doctor as a witness. The doctor acting as a witness will have the duty to make an assessment to ensure that the patient fully understands what is going on. If it is obvious that the patient does not have the ability to understand or convey their wishes, then the process cannot be completed. No, it's about difficulties they have encountered. They have told the hospital authority in 2024 and they met with them, so they are able to communicate their wishes. So it's not about a reception of information and expression. So what difficulties are you talking about? For example, training. The training is mainly on geriatrics in end-of-life services, but the cases are not followed up by specialists. So you said you have enhanced training and guidelines. That's why I said that I will not go into it. But there is a group of patients suffering from rare diseases. They have difficulties. Perhaps you need to reach out to them to see what they are, what difficulties they have, or if these difficulties have been overcome. I would like to stress that for advanced medical directives and do not attempt CPR orders are something that should that the 17,000 doctors and nurses in Hong Kong should know. I talk about oncology, palliative care, as well as geriatrics, and there are more of these cases. But for other disciplines, a patient may, at a certain stage, choose not to resuscitate. I don't think there is a discipline that doesn't know about the arrangement. Perhaps you need to give us more specific information about the difficulties encountered in 2024. Can you find the information? If there is a chance for them to enhance communications, that would be good. Maybe you arrange with the hospital authority for a meeting. If there is information, please forward it to the administration. Please give a specific information.
Yeah.
Next, Reverend Ms. Peter Kuhn. I'm in strong support of the AMD implementation, but a lot of citizens ask. They concern about further instruction when they are terminally ill. Who can represent them to make this decision? For example, especially for some, they would like to give the decision power to those without biological relationship. In fact, the AMD implementation is about letting the patients make their own decisions. If the mental state of the patient changes after making the directives, when they are no longer mentally capable to make directives, it's not about so no one is legally permitted to make the decision for them. I would like to clarify, because a lot of people would like to, regarding the final stage of their life, their affairs can be decided by someone else, because they voice out that it's nice that they have AMDs now, but maybe for the next step, will there be someone to decide medical procedures in the final stage of their lives? It's an issue. It's a very difficult, tricky issue for patients who didn't make AMDs and they suddenly fall ill. Who's responsible for making medical decisions? This is what our frontline workers often face. Maybe there are several siblings or children. So will there be an instruction made as for who's making the decision? Because in a legal point of view, there can be a enduring power of attorney to decide who's making the decision, but this is only about how to settle their financial arrangement. But then, according to the law itself, this cannot be applied on their medical arrangement. So even if they have EAP, they are not allowed to decide on the medical arrangement. So will there be a legal framework for this? Because the patients are very happy about this ordinance. So although the EAP settles their financial affairs, how about the medical instruction? Whether the EAP can extend to non-financial matters, we will discuss with the Labor and Welfare Bureau and other relevant bodies, because it's very complicated issue. Our frontline workers face a lot of these every day. So last, Mr. Shiu Ka-fai. In paragraph 10, it's mentioned that patients at a very late stage, they issue a directive. They need the approval of medical practitioners. So I would like to know what role does family members play here. If the patient decides they won't be saved and medical practitioners also approves, can family members say no to that? The medical instruction is made when the patient is in conscious state, so family members are not allowed to change it because it's made by the patient itself and there's a witness. But when frontline workers, if they run into family members with a different opinion, in principle, the family members cannot make any changes. I would like to invite my colleague to talk about what's going on in the front line. If the patient has already signed the form, but the family members don't agree, then what will happen? So every time when we discuss ACP, we will meet with family members, and we strongly encourage family members to join the other family members to join the meeting. We want to reach a consensus because we respect that in Chinese culture, patients may not have the right to the right of decision does not always lie solely with the patients. Their children and their family members may have a say. So in our guidelines, we emphasize communication and consensus. Although family members do not have the legal rights to say no to a patient's decision, we hope that prevention will prevail treatment. We would like to play safe, and family members will be aware of the arrangement. Of course, in the final stage, things may change, and we have encountered that. Okay, time is running short. I would like to ask if the patient obtain approval from 2 medical practitioners and they don't want family members to be present. Is that possible? We will encourage. If they still say no, is that possible? Yes, it's possible. So I also see in paragraph 10 that after the patient make a directive, they signed in the very final stage, but then the order is only valid for a year. But so that means it should be renewed every other year. Yes. For DNA CPL orders, when doctors sign it, it means patients already satisfy the requirements. Doctors really need to review whether patients change their minds or whether they still satisfy those requirements. So if they don't sign, then it will no longer be valid. If it expires, then it's not valid. So will it annoy the patient? They always have to sign. The directives are signed by the doctors, but not the patients. It's not by patients. When the patients are unconscious, they can still sign the directives, the order. So the 2 doctors need to sign the orders for them once every other year. Patients who sign this order are in their terminal stage, in the very final stage. Their heart may stop at any time. So they won't sustain for a very long time. So doctors will continue to sign unless there are drastic changes to the patient's situation. Okay, I support. Thank you. Thank you, everyone. It's 12:53 now. Our meeting will end at 1 p.m. today. We still have one item. I know that the CUHK Medical Center staff are already present. So, Mr. Tang Kapiu, I'm a non-member. I hope that everyone understands that the CUHK President, Mr. Cha and Mr. Chen, and the President of the CUHK are present. I hope that we value this opportunity to interact with them. And there's news, so we would like to leverage the hype and discuss about discuss the CUHK Medical Center. We would like to extend the meeting for half an hour. So I would like the chairperson to use his power to extend the meeting. Mr. Xu, please. I would like to thank the stakeholders for being present, for coming, and I apologize for our long discussion. But I think it's the meeting has there's enough time for us to discuss 2 items, but 3 items is too difficult. The meeting will end at 1 p.m. today. The 2 items have not been covered, but 3rd item has not been covered at all. Some of our members have already have other commitment, so is 15 minutes enough for our colleagues to voice their views on CUHK Medical Center? I know our colleagues would like to leverage the hype, but then is there enough time? Maybe next time there will be more time for us to discuss the matter in depth. I would like to apologize to CUHK Medical Center staff. I agree with Mr. Xu. We respect that the CUHK Medical Center staff, and I think there should be more time for us to communicate. 15 minutes is not enough. With such a packed agenda, it's not really possible for us to go into everything in depth. And some of our colleagues have already left their seats, so I hope that next time there will be more time for us to interact with the CUHK team. And there will be more time for us to touch on the matter. 15 minutes is not enough. So we'd like to clarify that we can have an extension longer than 15 minutes. If there's an extension, is Dr. Lo available? I'm okay. Ms. Fong Kok-chan, I support an extension. Ms. Chen, Chairperson, actually, in the last meeting, there's not enough time for 3 agenda items. You can see that there's, even if there's an extension, it's a meeting for all members. I think that this item, the CUHK Medical Center, it requires more discussion. A lot of electrical members are very active. I can stay behind, but then some of my colleagues have other commitment. They have other meetings. So I think we need to engage all the members and those who are interested. If they're not engaged, then I don't think this is very appropriate. I see that the CUHK team is present. If we ask them to come again, then it may be quite difficult for them. Some who don't agree with staying behind an extension. It's a 3-to-1 objection. Do you want a round of vote? If nobody is willing to stay, so we'll end here. We will schedule another meeting with the CUHK team. Thank you, everyone. We have another item as well. The Kai Tak Hospital will come into operation in phases. There will be a site visit, and it will be arranged. Do members want to join the site visit? If there's no other opinion, the Secretariat will discuss with the government to actualize the details and send a letter to members, and we'll also invite other members. The meeting today is concluded. Thank you.